Hello everybody, this is Dr. Medicine RX, and in today's video we'll be discussing about Staphylococcal scalded skin syndrome, also known as 4S for short. So this disease is also known as Ritter's disease or pemphigus neonatorum. It is a superficial blistering disorder that is characterized by detachment of epidermis. Here the cleavage of epidermis is through stratum granulosum, which leads to the formation of tender flaccid bullae. These blisters over large areas give an appearance of a burn or a scald. Coming to the individuals in whom 4S is seen. So individuals who have decreased renal clearance of toxins and also who lack toxin neutralizing antibodies, such as infants, young children of less than 5 years age, adults with chronic renal insufficiency, and immunosuppressed individuals. Coming to pathogenesis, the causative organism is Staph aureus, phage group 2 strains. So these strains, they have the capacity to produce two exotoxins, also known as exfoliative toxins. So the two types of exfoliative toxins are exfoliative toxin A and exfoliative toxin B. Exfoliative toxin A is chromosome coded and exfoliative toxin B is plasmin coded. So these two exfoliative toxins, they bind and cleave desmoglein 1, which is a type of desmosomal protein, leading to the splitting of desmosomes. So these desmosomes are necessary for keeping the cells together. As a result of which, there is disruption of the cells in the granular layer, leading to bulla formation. Since there is no desmoglein 1 in mucosa, it is spared. So desmoglein 1 is seen only in the skin, so blistering of skin is seen, whereas in mucosa it is not present, so mucosal surfaces are spared. The source of this S. aureus in the individual can be in their own nasopharynx or conjunctiva or in their own infected wounds. Coming to the clinical features, at first there is going to be a prodrome of fever, malaise, irritability and tenderness of skin. After about 24 to 48 hours of this prodrome, there is going to be erythema, which is firstly seen in the head and also on the face, and later it involves the intertriginous areas and later involves the rest of the body. This erythema is followed by formation of large, fragile, flaccid, sterile bullae. So each term is really important for describing the bullae seen in 4S. So they are large, they are very fragile and flaccid, and they are sterile. That is, there are going to be no bacteria present on culture. So these bullae, they rupture easily, leading to formation of tender patches on skin with a varnish like crusting. So this top layer, it peels off easily in large sheets, and over the next 3 to 5 days scaling and desquamation continues. This is followed by reepithelialization without scarring. The bullae in 4S are also seen on areas of friction over the center of face and also at the orifices, and Nikolsky sign is positive. So there is a picture showing sheets of desquamated epidermis. Coming to the complications, hypothermia, loss of body fluids and salts leading to dehydration and electrolyte imbalance, renal failure, and secondary infections such as sepsis, cellulitis and pneumonia can occur. Coming to diagnosis, the diagnosis is usually clinical and is suggested by taking a thorough history and also doing a thorough physical examination. Detecting Staph aureus from skin swabs taken from suspected infection sources or from the blister fluid, blood culture if sepsis is suspected, zinc smear of the bullae, skin biopsy which shows sharply demarcated zone of cleavage at or below stratum granulosum, and for detecting toxins, ELISA, agglutination test and double immunodiffusion test can be done. Coming to management, hospitalization is necessary in severe and generalized cases. NSAIDs are necessary for fever and pain relief. The patient should be started on IV fluids, and regular monitoring and maintaining of fluid and electrolyte intake is to be done. Skin care in the form of gentle washing, emollients for maintaining the skin barrier, and regular skin dressings are necessary. Coming to the drugs that are need to be given, beta-lactamase resistant antibiotics such as flucloxacillin, either oral or IV for a minimum period of 1 week is to be given. Clindamycin can also be tried because it can reduce toxin production. Mupirocin, that is a topical antibiotic, is also be applied. Parenteral vancomycin is to be given if methicillin resistant Staph aureus are detected. Complete healing following treatment occurs in 1 week, and the mortality rate is higher in adults and lower in children. Coming to the differentials of 4S, SJS or 10, bullous impetigo, toxic shock syndrome, graft versus host disease, viral exanthem, ADR, adverse drug reactions, and pemphigus foliaceus. Thank you and subscribe for more.